A very warm welcome to Dorset Humanists this afternoon. This year we will be celebrating our 25th anniversary, and in November we're going to be hosting a special event for our members. One of the many benefits of paying your £15 per year. If you're not yet a subscribing member, I'm sure most of you are, but if you're not yet a subscribing member of Dorset Humanists and you'd like to be, just head over to our website and click on the Join tab and everything is explained there. Okay, well, our speaker today is Barry Newman. Barry is a retired intensive care medicine consultant, and this is his third talk for Dorset Humanists. His last talk for us last year was on the problem of ageing. So perhaps his talk for us today is, in a funny sort of way, a logical extension of his last talk. He qualified at the University of Cape Town, and he was appointed consultant at Poole Hospital in 1988. Barry is going to divide his talk into 3 sections, so you will have 3 opportunities to ask questions or make comments. We are recording the event, so if you really do not want to be seen on the recording, you may wish to turn off your video, but you can still participate via audio if you would like to. Well, I'm sure you will join me in giving Barry a silent, but nevertheless a very warm welcome. So Barry, over to you. If you'd like to share your screen and unmute yourself, we can get on with your talk. Barry, I think you're still on mute.
How does that sound?
That's it, yeah.
All right.
That's great. We can see
the buttons to press. So, David, can you confirm you can see a blue screen?
We can see the screen and we can see the thumbnails at the side as well at the moment.
Okay, it's probably better that way, because then I know where I am.
Okay, fine.
All right, so thank you very much, David, for inviting me to give this talk, which is about an old chestnut subject. I know that you've had discussions on the subject before, some years ago, but sadly I think the subject can and should return regularly until the matter is resolved in this country and we have some way forward. Interestingly, it's currently become quite topical in the media recently because of the sad news that Henry Marsh, who I believe is a great supporter and patron of Humanists UK, has been diagnosed with a terminal cancer, and he's been very much in the press speaking about his experience, which is very moving, but also promoting the idea of legally assisted dying being brought into this country. So it's not bad timing for us to be talking about this. As David said, I'm going to break the talk as I've constructed this into 3 distinct parts, and I'll be breaking after each one because I think it'll be better to have discussion that way. But if the discussion goes on, forgive me if I break in because I'll need to carry on to cover all the material. So the 3 areas that I'm going to discover, 3 headings that I'm going to discuss this matter under, are the what, the why, and the how. I hope nobody thought that the how was going to be the actual mechanics of how to end your life, because I'm not talking about that at all. But what I'm talking about is some definitions and explanations. And the reason for spending a third of the talk on definitions and explanations is that I have found that most people, when they discuss this issue, the discussion becomes derailed because people are using words and assigning different meanings to words, and therefore the discussion tends to go past each other. People talk past each other, not to each other, because they're not using the same words in the same way. And to have a reasonable, logical discussion about this in any subject, I think you need to define and explain the terms you're using so we're all on the same sheet. The second part of the talk will be a very brief summary of why, the arguments for and against assisted dying. And then finally, I'll give you a helicopter view, an overview of the law globally in other countries and locally in the UK. So off we go. First of all, a definition of what I'm talking about. Assisted dying is a procedure performed after an explicit request by a patient where the intention is that the procedure will lead to the patient's death. Now, as such, no jurisdiction in the world yet allows non-physicians to provide this assistance. So more accurately, it should be called, and usually is called, physician-assisted dying. And that is what we're talking about. So I won't be talking remotely about anybody other than a physician assisting dying in a sort of medical setup, medical situation. So let's launch into 2 slides of terms. First of all, there's autonomy, the right of a person with full mental capacity to make their own decisions. And full mental capacity has a very specific meaning in most countries, but in our country it's defined in the Mental Capacity Act of 2005. And there are 4 requirements for a person to have full mental capacity. You need to understand the information given. One needs to retain this information. That is, if you're asked about it an hour or a day or a week later, you still have it in your mind. You need to be able to weigh this information in the balance. This is very hard to establish, but you need somebody who shows the signs that they can think about the information and think about it in relation to other factors and arrive at a decision about it. Very, very hard to know if anybody, any of us, are really capable of weighing anything in the balance properly, but that's what the law says. It's pragmatic. And the 4th requirement is that people must be able to express this wish, and this deals with people who have communication difficulties specifically. So you need all 4 to have full mental capacity in the UK to express your autonomy legally. Best interests, on the other hand, is a decision made for someone only where they have inadequate mental capacity. It's a decision made for them in their best interests. But of course, their best interests are not defined by themselves, but by the others who have the duty and the responsibility to make these decisions. When I talk about physical ability, I'm talking about the physical ability to self-administer medication. And this is important because, as you'll know from previous very tragic cases, that there are people who are so paralyzed that they cannot lift their hand to their mouth and they cannot swallow. So to take your own, to end your own life, in some circumstances, you need minimal physical ability, and that is basically the ability to put something in your mouth and swallow it. And an advance directive is a recording of an instruction to be carried out after loss of capacity. Something you write down when you have full capacity, that is usually witnessed and dated and stored away carefully and brought out at a time when the circumstances are appropriate and when you are not capable of giving direct instructions yourself. A few more terms, I fear. Palliative care is a medical treatment to reduce suffering and improve quality of life for those with terminal illness. Terminal illness itself is defined variously as incurable, progressive, imminent, and inevitable. All these things are difficult to pin down. Terminal illness is a particularly tricky one. We'll come on to that a bit more later. The double effect comes up in discussion quite often, and I'll bring it back later. And the double effect is a treatment which is primarily intended to alleviate suffering, but that might also hasten death. It has 2 effects, a double effect, but it is acceptable and legal if the primary intention is to alleviate suffering, not to cause the death. And assisted dying is, as we said before, assisted by a physician. There's one jurisdiction in which specialist nurses can do this, but I think it's easier just to think of it as physician assistance. And euthanasia is a term used with widely differing meanings. It's used rather loosely. It actually means a good death from the original Greek. And it's applied indiscriminately to various scenarios. So it is a source of misunderstanding and confusion. I get quite concerned when I see that word in the press or anywhere else, because I know that half the people will interpret it one way and half another. And for that reason, I will not be using this term in the presentation. So you might be surprised, but I'm not actually going to be talking about euthanasia at all. To move on, now that we understand most of the terms, there are two criteria for justifying assisted dying, two reasons for raising the possibility. One is terminal illness and the other one is unbearable suffering. As I've said before, terminal illness can be defined in a variety of ways, but almost always implies that life is going to be significantly shortened by a diagnosed disease, an identified disease. Some jurisdictions state a period of time, which I always find concerning, because if a doctor ever tells a patient that they have X time left, you can be sure, almost 100% sure, that that doctor is going to be wrong. The death will either be earlier or later, or sometimes a great deal later. So defining terminal illness in terms of a time period is pretty tricky. Unbearable suffering, which is also described in some sources as untreatable or unending or all three, it's important to realize that this is subjectively assessed. In other words, it's the sufferer's view, not anybody else's. And that can be quite difficult when you have family who are, shall we say, not quite in tune with what a person is going through. Very important to focus on the subjective experience of the sufferer themselves. A difficult and interesting twist to this issue of unbearable suffering is that it may be caused by physical or psychological problems. And psychological suffering takes this discussion of assisted dying into very difficult territory indeed, which I'll return to a little bit later, or you may wish to raise in discussion. Valid patient circumstances for assisted dying are two. There are two criteria and combinations of them that constitute the correct circumstances for considering assisted dying. That is, a person with or without mental capacity and a person with or without physical ability. How do we break these down? I'm going to look at three combinations because the fourth isn't relevant. First combination is a person with full mental capacity plus the adequate physical ability. And in this situation, a person can be given the means to end their life, but is not physically assisted at all. And this is the pattern that is used in a place like Dignitas, where patients who have full mental capacity and the ability to pay and travel to Switzerland, and they have adequate physical ability to self-administer medication. This constitutes situation or circumstance number one. Circumstance number two is a person also who has full mental capacity, but inadequate physical ability. And here the person is requesting that somebody else administer the medication. This is an added layer of both ethical and legal complexity. But these cases do happen with sad regularity. And as you'll know, there are people with advanced neuromuscular degenerative disorders who lose the ability to move their arms and to swallow properly. So this is a very real issue. The third circumstance is a person without mental capacity. And here physical ability becomes irrelevant. Because if they don't have mental capacity, then the ability ceases to become a relevant factor. if a person, assisted dying here, if it's allowed at all, would be under an advance directive that was made when the person did have full capacity. So here we're talking about substituted judgment. I beg your pardon, let me rephrase that. There's another alternative to assisted dying without mental capacity, without adequate mental capacity, and that is a substituted judgment where no advance directive has been left, but someone else is legally, morally empowered to act in that person's best interest and administer something. This, as you will appreciate, is quite far out on thin ice, ethically and legally, where a person has not declared an advance directive about assisted dying, but the law can, but does not yet, allow a substituted judgment that somebody else, a committee of doctors, a lawyer, an ethicist, perhaps somebody from a religious background, if it's appropriate for that person, they are empowered to make a substituted judgment for the person who cannot make it themselves. That's a tricky one. So at this point, I'm just going to stop because I've been talking for about 15 minutes, and that's what I intended, and ask you if you have any comments, questions, any discussion now for 10 or 15 minutes, and then I'll carry on.
Thank you very much,
Stop sharing.
Barry. So, yeah, I think we'll, if you would like to ask a question, if you could raise the blue hand, and that's going to be easier for me to.
I could do that.
Okay, so Aaron, you're first up with your blue hand. So, Aaron, do you want to go?
By all means. You had those two categories of terminal illness but no suffering. If somebody had terminal illness and would say, well, you're going to die in 6 months, 3 years, 12 years, but there was no suffering, would that have a criteria for end-of-life circumstance?
It would depend on the jurisdiction and the law, and I'll come on to those, and they're very various. The law can state that you must be suffering. The law must state that you must have a terminal illness. The law can state that you require both. There are permutations here, and different countries have gone down different paths, which is why it's a very appropriate question. It's a tricky area, and there are different paths you can go down to legalize assisted dying. It can have different requirements. And you've mentioned two of them.
Okay, thank you.
Okay, thanks, Aaron. Let's go to Dan next. Daniel.
Sorry, I had to unmute myself. Do you think it counts as somebody being mentally capable if they're extremely depressed, and there's a chance they might get better from that depression, but who knows? And they really want to die, but if they weren't depressed, they might not want to die. And you know, they would probably pass all of the tests for mental capability, like they can solve maths problems and things, and otherwise seem relatively mentally capable, other than the deep depression. Yes,
well, you've charged right into a very complex and interesting area. Thanks for that. Physical suffering we can all relate to relatively well, understand it, and empathize with it. Mental suffering is a different ballgame, and depression is particularly difficult because there's such a vast range. And we do know that in most cases, depression is either treatable or self-limiting. However, there is a subgroup of people who suffer from what used to be called in the old days endogenous or primary depression. That is, depression as a disease rather than being depressed about something. So severe depression, which is marked by a very poor quality of life, multiple suicide attempts, and a persistent, clearly expressed view that life is not worth living at all. And there have been a couple of cases, more than a couple of cases, in Holland where assisted dying has been permitted for severe irreversible mental illness, which was a combination really of depression, personality disorder, and a few other things. But yes, you raise a very good point. In the vast majority of people, not everybody, depression is self-limiting, and this raises problems. On the other hand, there are people who suffer terribly from lifelong deep depression and have, in their eyes, unacceptable quality of life. So another difficulty to resolve. Sorry, I don't have answers to these things, but they're all the right questions.
Well, thank you. That was a very interesting answer, anyway.
Thank you, Dan. Let's go to Phil James next. Phil, what's your question or comment?
Can you hear me?
Yes.
Yeah.
Now,
Yeah. Thank you. Well, hello. Fascinating topic. So my question is, I wonder how what the prevalence is of people who are terminally ill and being treated and given, for want of a better word, an overdose of morphine, not necessarily with any of their own volition. Is that a clinical judgment then? Is that what I'm probably talking about, is it?
I'm not 100% sure what you're asking. Are you suggesting that patients are purposefully given lethal doses of opiates with the primary intention of ending their lives?
That's what I'm wondering. That's what I'm questioning, whether that is at all prevalent.
Well, I would say, I would hope not, because what you've just described is murder. If you give a medication with the primary intention of ending life, that is by definition murder. However, if a person is suffering severely and you give a high enough dose that has a real chance of shortening their lives, but the primary intention was to relieve suffering. It's all about intent in law. If the primary intention was to relieve suffering and the secondary effect was a shortening of life, that is a valid use of the double effect defense.
Gosh, that's quite a tricky one then, isn't it, really?
Not really if you do it day in, day out in palliative care. It becomes quite clear in your mind.
Right, okay.
You're primarily treating suffering with a drug that has a side effect of potentially shortening the patient's life. On balance of risk and benefit, administering those doses is better for the patient than allowing them to suffer for a day or a week or a month longer. That's the logic.
Thank you. Yeah, perfect.
Okay, thanks.
Thank you, Phil. Barry, we've got 4 more questions at the moment, so I'll keep going until you...
Yeah, another 5 minutes will be fine.
Okay, let's go to Paul next. Paul.
Barry, is it legal to ask for or put in assisted dying under certain conditions in your advance directive?
It depends where you live and whether advance directive is an allowed route to assisted dying, and there are very few, if any, jurisdictions that currently allow that.
Sorry, I meant England, which is illegal to do assisted dying.
Well, I'll get on to the sad situation of the United Kingdom later, but no assisted dying is legalized in this country at all in any form. Anybody else?
Okay, let's go to Simon Whipple. Simon.
Right, I'm carrying on from Phil James's point, really. What concerns me is that despite what Barry said, I've got anecdotal evidence of several cases of doctors deliberately over-prescribing for humanitarian reasons with the intention of bringing about a death. There was a case some years ago of a doctor in Winchester who was found to have overprescribed and led to a death, and he was charged with murder, and the the anecdotes I heard from other doctors was that this was prevalent. Of many doctors did this, knowing it put their own career at risk, but believing it was the right thing to do. Now, the point I'm really making is that if this is what actually happens, we should perhaps look at this square in the face, rather than, I mean, I'm sure there are many cases where it is done as a dual effect, but essentially, if we're looking to change the law in the UK, we ought to accept that doctors do prescribe with the intention of bringing out death quite a lot, and therefore something that protects the doctors and allows them to be honest at what they're doing may be very worth having. So I'm not really making a question, asking a question. I'm really making a point about it, that we should be clear as to what really is happening. I suppose there is a question there as to whether you could actually agree with what I've just said, Barry, that this really does happen in considerable numbers.
Well, the simple answer that I can offer is that I don't really know, and I'm very wary of anecdotal comments in such a complex and difficult field. Can I just clarify about the doctor in Winchester? This was a chap called Cox, a rheumatologist who had been treating a particular lady most of her adult life, and she was in perpetual agony. And he administered not a painkiller, but a chemical, potassium chloride, in the stated belief that he thought potassium chloride would potentiate or make more effective the doses of morphine that she was giving. But of course, potassium chloride intravenously kills you stone dead because it stops the heart. And the reason he went to court is that his very public act of doing it on a ward round in front of a whole lot of staff and patients, and the drug he used were both very unusual. And it is notable that although he was prosecuted, his sentence was token. He received a token sentence. He was simply doing what other people probably do, but he had the courage or stupidity to do it publicly.
Yes, so what I heard is that actually there was a bit of unpleasantness from one of the other people present.
I think it was one of the nurses who objected.
Politicking.
I think there was a nurse with a religious background who raised the objection, and it went legal. Yes. It's 5:30. I can take one more, and then I should really get on.
Can we take two more?
Right, briefly, if I can.
Two people have been waiting. So if we can ask the questioners to be fairly brief. Carolyn Meller, first of all. Carolyn, you're on mute at the moment. We can't hear you. Are you able to unmute? That's it.
There we go. Hello, Barry.
Hello.
Where does removing nourishment and water fit in to this subject?
A quick answer there. It doesn't at all, because it's not assisted dying. It's the withdrawal of supportive care where it's deemed to be not in the interest of the patient. So it's an allied but unrelated legal and ethical issue, the withdrawal of artificial nutrition, hydration, because in those patients, none of them have capacity. They're all very severely mentally damaged. So it doesn't really fit into this at all. It's a very fascinating area, but it's not this area.
Where does money come into it?
I don't really understand the question, I'm afraid.
How far along the line does the budgetary constraint figure in making a decision as to whether a patient can be assisted to die or have support to life withdrawn?
I would say that money doesn't come into it even remotely, not in this country.
Okay, thank you.
Okay, thank you, Carolyn. Let's just take one more from Simon Bowden. Simon, do you want to unmute yourself?
Right, hello. Can you hear me, David?
Yeah, I can
Yes,
hear you.
yeah.
Okay, so I'm with the two oldest attending members of this humanist church that we belong to, and this won't be. I want to give each of them a chance to say something, and I'm afraid it's not a very specific point relevant to Barry, but these people have come here at incredible practical difficulties. So if we can have a moment to make three different points from us. My point relates to a fantastic Woman's Hour item about 3 days ago on coming to terms with dementia. And it started with an interview with a lady diagnosed with dementia 7 years ago. Since then, she'd written a book sort of describing the experience of living with very diminished faculties, as anyone in their 90s almost certainly does. And she made the point that human consciousness is, she described as being a bit like fairy lights, and sometimes they sort of flick on and off, and sometimes some bulbs go out. So in her case, she can't cook, this author, she can't taste, she can't feel hunger anymore, but she can type. She was a lively, intelligent lady, and she made the point that we need to cope better with the long periods after which we've lost a lot of faculties, but there are still things we can do and enjoy. Now, both the ladies here, there was one further point really, which is how tremendously difficult it is to communicate correctly if, significant parts of my brain aren't working. People are trying to help me, but I have my own agenda, and there's just incredible possibilities, as we have in my family living with Angela, of kind of bad-tempered interactions where my brother will routinely swear at her and accuse her of being a moron and stuff like that. And it's not, it's how you seem, when you're very, very slow and you've lost some abilities. Now, both these ladies with me have experienced some of the depressive effects of, living on into the 90s and partly being capable, partly being incredibly frustrated. They both have an strong interest in the subject. And I'll be very keen to let each of them say something about it, because they were very keen to come here. So it's not a technical issue, it's the practical issue of when we frankly get fed up with life. We've just had enough. But I would like each. So I'm going to pop this over. Okay. Anne has made the point that Andrew is the older. Andrew is 94 and is thing of 92. So she's saying, but could I just ask each of you, why are you interested in euthanasia? Why listen to this talk? What are you hoping to get out of it? Yeah, that's fine. Just hold it there and talk. Yeah.
Well, I think it's difficult for doctors to have to break the law, and it's very difficult to take an overdose. And I've sometimes wanted to be dead, and then a few days later I've been really enjoying myself, and I'm glad I'm still here. So it is difficult.
Thank you, Angela. It's good to hear you. And
I'm going to pass this to Anne now, Anne Siv, who incidentally met Prince Philip several times. But yeah, here we go.
Oh, very good. Hello, Anne.
I was very interested in the comment that Tom Stoppard made, which I cannot now find, but I found the other day about it. And what I want to know is, if there is a growing majority among the medical profession for allowing people to have, what is the point of having a DNAR when nothing can be done about it, that more could be done to allow people to say, I've really had enough, and more than the share of what I want to do on this earth, especially if you have no close family And if your means are reduced and you're no longer something taxpayer,
like a productive citizen, or?
No. Yeah, well, certainly a productive citizen. But you can't get around, you don't intend to travel anymore. And something of that nature. I did make a note of Tom Stoppard, but of course what he said, but I can't find it. But of course he was married to a doctor.
So I mean, Anne, you've just read a really interesting book, haven't you? So you still have large areas of life that seem impressive and worth preserving.
Well, just for myself, what's the point? I have just read Antonia Fraser's marvelous book on the 1832 Reform Act, which I think is very relevant to some of the legislation that is going through Parliament today. And she dedicated it both to her father, Lord Longford, of notorious fame because he was such a defender, seemed to be, of Myra Hindley, the mass killer.
Anne, I'm going to just get Barry to respond briefly now to the points that you and Angela and Simon have made, and then Barry's got some more slides to show us. But it's been really, really wonderful to hear, from both of you and Simon as well. So thank you very much. But we need to go back to Barry now.
Can I just say that several of the points that you both raised are very, very relevant. Thank you for raising them. I'll touch on them very briefly now, but perhaps we can expand on them a little bit later. The issue about feeling in one way one day and in another way the next day, that is feeling down and wanting a life to be ended and then having a good period, is an extremely relevant one. And most jurisdictions that allow assisted dying require that this should be a settled and permanent view. Those are the words used. So vacillation is regarded as a reason for delaying the decision. So this issue of having good days and bad days is very much recognized in law. It's a real issue. The second issue brought up was, how do doctors feel about breaking the law? Well, anxious, I would imagine. But I can say that medical opinion in this country and in most countries is shifting really quite rapidly, and I'll cover that a bit more later. So if I could just share screen again, I'll go to share screen.
Thanks, Barry.
That one. Talking to myself here, it's not a good sign. Right. I'm now going to go through objections to assisted dying. And as I see it, there are 6. There are probably more, but you could make them into less. This is just an arbitrary list. And I really have a slide on each, so I'm not going into any depth whatsoever, but just to raise the range of objections to assisted dying that people come out with in debates on it. The first is a spiritual objection. And this is very much my take on it. So forgive me if you disagree. I look forward to hearing the disagreements. Concepts of the sacredness of life. Looking up the word sacred in the dictionary, you come across words like respect, veneration, awe, taboo, preference. Usually, sacredness of life is couched in terms of being related to a life-giving deity. Furthermore, that this life is owned by or originates from the god, and it is often lent to a person by the god, and sometimes lent for a specific purpose. But the bottom line seems to be that the person has no right to end it, and that only the god has this right, because the god owns the life. I did ask myself the question, is there a secular or perhaps humanist version of sacredness? And I suspect there is. There is we can adopt rationally a moral philosophical principle about the value of life without inferring a deity. And we can arrive at this principle about the value of life by reason rather than by adopted faith. So I think spirituality or spiritual objections doesn't necessarily imply religiosity. The second set of objections are medical objections, and they overlap slightly, but they sound something like this. Assisted dying is said to be fundamentally inconsistent with a physician's role as a professional and trusted healer. Nice old-fashioned phrase. Doctors are supposed to save, not end life, but doctors are also there to relieve suffering. So these two can conflict. It is claimed that assisted dying will damage the doctor, the physician-patient relationship by undermining trust, trust being quite essential in the relationship between a doctor and a patient. There is the palliative care argument, which probably warrants a discussion all of its own. But the palliative care argument runs something like this, that suffering can almost always be controlled as long as there are adequate resources. There's always this, if we had enough, hospices, nurses, doctors, and so on. I have to say that the world of palliative medicine is also shifting its attitude after a long period of stalwart resistance to assisted dying. And I would also have to say that some doctors are afraid that they will be compelled to cooperate with assisted dying, but must point out to you that a person has no right to decline a treatment. Sorry, a person has a right, of course, has a right to decline treatment, but you have no right to demand a medical act. So that doctors can decline to offer some treatments if they ethically feel that way, and an obvious example is termination of pregnancy. So that is not a valid argument, really. Moving on to the next set of objections, we have the limits to autonomy objections. The limits to autonomy is a complex and philosophical, political discussion. An individual's right to autonomy does not necessarily take precedence over the norms of a society or the greater good of society. That is, other factors can trump your autonomy. Philosophically, you can state it in this way. Personal autonomy does not hold a more privileged position in deontological or consequentialist views on the sanctity of life. Just two ways of saying the same thing, really. Just to expand on this very slightly, because it's a very important issue, I think it's fair to say that autonomy is a cherished principle in Western philosophy and international and national human rights law, that you can make your own decisions, that you're your own person. And the law goes a very long way to protect this autonomy, unless your autonomy is restricted for a specific and limited purpose. Autonomy in selecting, accepting, or refusing medical treatment is standard. And as you well know, although it can harm other people, you and many people out there can and do decline vaccinations. So there you have the interesting clash and balance between the needs and rights of a society and the autonomous rights of an individual. Must point out, of course, that autonomy is often relinquished for communal purposes. You and I don't have the right, the autonomous right, to go out into a car, get into a car, not put our seatbelts on, and drive on the right side of the road. We don't have that autonomous right. We are giving up these freedoms for other benefits, theoretically. Autonomy, as I said before, is restricted by law for explicit purposes, and that we have no right to demand a treatment. Apologies, I think I'm just repeating myself slightly there. Moving on to the next important, emotive, political, confused, if I may say so, argument against assisted dying. And these are the objections made by or on behalf of the disabled. It is claimed that assisted dying diminishes the value that society assigns to the disabled. It is also claimed that inadequate living support for the disabled predisposes to such a poor quality of life that these disabled people request assisted dying. And such cases have actually arisen in the United States. It's claimed that assisted dying invokes the slippery slope to non-voluntary, in quotes, euthanasia of the disabled, a fear that we are going to get into some dystopic world where people who aren't quite the ticket get bumped off. This is a fear. It should not be disregarded. There is a really interesting and difficult problem, yet another interesting and difficult problem, I should say, that this field is absolutely littered with them, of capacity for fully informed decisions in those with intellectual disability or autism spectrum disorder. And there's been a paper published recently on 2 or 3 cases of patients with ASD spectrum disorders in Holland, where their decisions for ending their own lives have been subsequently questioned. These are people who have taken their lives, but this is a retrospective analysis. Only a very small number, mind you, but still raises a question. And finally, there's great historical sensitivity about the word eugenics, the killing off of the inadequate, the doing Darwin, or more accurately, social Spencerism, because Darwin, of course, would never have and did not suggest such an awful application of his description of nature. Then there's a set of objections based on uncertainty. Well, we're uncertain about everything in life. I'm not sure about you, but I'm absolutely certain about almost nothing. But apply it to this particular field, we can say that there can always be uncertainty about full capacity, mental capacity. As I said before, the conditions for mental capacity, like weigh things in the balance. Who can tell how well you or I weigh things in the balance? How can we tell that we are adequately informed? What does adequately mean? And enduring, this comes back to the point made earlier. Can we be absolutely sure that a decision is enduring, that there's no change of mind? And entirely voluntary. Can we truly say that none of us are influenced by our surroundings, by the people around us, and that we have absolutely independent free will? I doubt that that exists, and that we are always influenced by things around us and people around us. There's uncertainty about medical diagnosis. All of you, I'm sure, will have, I beg your pardon, I don't know what's happened, but can you see me?
Yes, I can see you, Barry.
Can you see what? Let me just. There we go. You can see the slides now.
Yeah.
Okay. Sorry, something happened to the computer. My phone went, and the
Why does it say she, her?
Computer responded. Let's carry on.
Dreadful.
Uncertainty about medical diagnosis. I'm sure everybody will have read of or have personal experience of a doctor getting it wrong, obviously. So how sure can we be that the diagnosis is correct and that therefore the prognosis is correct? Uncertainty around diagnosis and prognosis. And then this chestnut is always thrown in at the end, uncertainty regarding future cures. What happens if a life is taken now and tomorrow a miracle cure comes along? It's not a terribly realistic objection, but it is often quoted under the general heading of objections based on uncertainty. And then there's, excuse me, the important and emotive and politically loaded issue of the slippery slope argument, also known as the erosion of safeguards. As you can see, I very artistically put a slippery slope over the writing. Oh dear. I'm still having that problem. Back to that. Firstly, let's start at the top of the slippery slope with voluntary assisted dying with full capacity and full consent, self-administered. Relatively safe situation in which the person is able to and does make their own decision and take the act themselves, undertake the act themselves. We go a little bit further down the slippery slope to voluntary assisted dying with full capacity, but inadequate physical ability. And here the person is requiring someone, usually a physician, as I said, to administer whatever has to be administered. Slipping down the slippery slope a little bit further, we have voluntary assisted dying with an advance directive. That is, at the time of the assisted dying, the person does not have full capacity, but expressed themselves previously in an advance directive, which itself should have fulfilled all the requirements. And the person had full capacity at the time of making the advance directive, but not at the time of the dying, of the assisted dying. Further down the slippery slope, we get an involuntary assisted dying with substituted judgment. Here, the person does not have capacity, has not made an advance directive, but someone, family, doctors, a committee, a court, are empowered to act in their best interests and assist the dying. The word assistance there becomes a bit suspect, doesn't it? And finally, at the very bottom of the slippery slope argument, we have the, as I say, dystopic circumstance of involuntary assisted dying, not in the best interests of a patient and their suffering and their quality of life, but in the best interests of society. And I think somebody touched on this earlier by asking about the cost. When does it become too expensive to keep somebody alive and bump them off? Well, we're well outside, I think, the current arguments about assisted dying. And I think it's a spurious objection to raise, but it is raised and therefore must be considered. Next up, we've got just two arguments in favor of assisted dying. But I think they are powerful enough to hold their own position. The first is respect for human autonomy and self-determination, which we in Western culture regard as sacrosanct, if I can use that religious word. A person being an end in themselves and not a means to an end, a person having self-determination, the right to make their own decisions, is deeply, deeply entrenched in our culture. Secondly, there is the relief of subjective suffering. No one, I think, could reasonably argue that we have a right and a duty to alleviate suffering. And if an individual regards that their suffering is so great that their life is without value, then we should perhaps respect that. And we should also recognize the limits of palliative care. And as I said before, the palliative care lobby or speciality is now recognizing that they can provide a vast amount of relief from terminal suffering, but not always. And that in some quarters of the palliative care world, there is a recognition that assisted dying may well have a place in hospices. So yes, opinions are changing. And that is the end of the second session. The third session is really, as I said, a helicopter or roundup view of the state of assisted dying in various countries and jurisdictions around the world. And that won't take too long. And we've got 35 minutes left. So I think it would be reasonable for me to stop talking for a while and listen. I'm going to stop sharing. And over to you, David.
Yes, thank you very much, Barry. All very interesting. Carolyn, you put your hand up at one point. So would you like to ask a question or make a comment?
Yes, I would. I was thrown off and a little bit disturbed by the inherent, but basically, actually the historical point of male doctors in the slide that said enduring capacity. Has she changed her mind? Women are not hysterical. women are not less resilient than men, and putting that as gender specific really undermines society, undermines the people within society, and also harks back to the awful situations where women were described as too hysterical to make their own decisions.
Can I leap to my own defense?
Yes, please, Barry. Please do.
I put in she there because I was conscious that I've been using he in all the previous slides. That's the only reason. When you
them?
Sorry?
They, them?
Yes. When you start using plurals, the grammar gets rather convoluted. And in quite a lot of stuff that one reads online now in terms of ethics and philosophy, people are habitually using she right throughout. And you could say, well, what about the blokes? So yes, I apologize for that. And perhaps the slide in which I put the female gender may have been a little bit sensitive. It wasn't intended, and I was just trying to balance things out.
In that case, it does need changing.
All right.
Okay, thanks, Carolyn. Let's go to Greg Atkins. Greg, what's your point or comment? You're on mute at the moment, Greg, if you'd like to unmute yourself.
Yeah. Oh, Barry, I was interested in your slippery slope argument, because the end of it seems to end up where Hitler ended up. In other words, killing people who have got bad mental illness for the benefit of society, because you don't need them anymore and they're not productive. But that seems fairly obvious. But there was a situation arose with the coronavirus epidemic in Italy, or very nearly arose. I don't think it quite got there. But there was a situation where 50% of the people in intensive care with coronavirus infection were going to die. And there was a shortage of ventilators. So there were people coming up who were going to survive, or were very likely to survive, but who couldn't be given ventilators because of people who were probably going to die. So my question, I guess, is what would you do in that situation? Or maybe you don't want to answer it, but do you agree that it is an ethical dilemma at the end of this slippery slope? Because what do? Do you cut the people off who are on the ventilators who you think probably going to die, and give ventilators to people who might survive?
Or of working age.
At the end of the slippery slope. And I guess there are other cases on the battlefield that military doctors have to decide whether they're going to give expensive equipment or treatment to somebody who has got a small chance of surviving compared with somebody who's got a large chance of surviving.
Yes, well, Greg, what you're in fact, I think, talking about is the distribution of resources where there's overwhelming demand and limited supply.
Yes.
This can apply to many things. It can apply to food, medical care, and yes, the issue of inadequate resources did come up both in this country and around the world in relation to this pandemic, and will probably come up again, but is not really directly related to assisted dying. Assisted dying is more an individual decision where a person makes a request, so that the ethics and the politics and the economics around limited resources where there's excess demand is interesting, but if I may say so, not directly related to what we're talking about this afternoon.
Well, I was, if I could come back very quickly, I was interested at the end of your slippery slope. That seemed to be where you're getting to, what people were arguing, the situation you would get to at the end of it.
Yes, what I was trying to imply is not that there were not enough resources, but in an individual case, somebody might say that this life is of such poor value, it's not worth spending any more money on it. And as I would say, it is the bottom end of the slippery slope. It's right in the marsh, in the mud. And it's just a logical extension.
Along with the far right and the right-wing governments.
It's just It's just a logical extension of the argument, but I don't think it has much validity and hopefully never will have. If it does, I hope I'm not alive to be in that world.
I'm sorry, Carolyn, but I'm going to mute people who just want everyone to be on mute whilst, just so that I can control the Q&A fairly. Okay, Greg, thank you very much for that. Let's go to Lisa and Richard. Lisa and Richard.
Hello there. Thank you very much for that talk, Barry. I found it very interesting and actually very reassuring with the safeguards that you were talking about of the different phases of consent. And personally, I think one of the most important autonomies for a human being should be a decision to be able to end their own life. And I would be very interested to hear how you think, briefly, you think that the law should be changed in this country, because I consider it to be quite inadequate at the moment. And I worked many years ago on a psychogeriatric ward for a long time with very, very severely incapacitated human beings who I felt that every single person there, had they had a window into their future 5 or 10, maybe 15 years earlier, would have actually chosen not to continue their life because they were completely unable to do anything for themselves. Some of them looked in constant stressed situation because they could not mentally, they did not have the capacity to understand what was going on around them. They had no verbal communication, and it was and no visitors, because they really weren't the person that the individual families had known. And I felt that the system was actually letting them down quite badly. They had very good nursing, physical care, and antibiotics when needed and stuff. But I felt that really your point about resources is absolutely true. The resources were there for them, but unfortunately, when somebody's brain is really to that level, it doesn't matter what resources you've got. If they're in a distressed state, there's no medication that you can actually give to help alleviate that.
Can I just come back on that, because it's a very important and very real situation that we have an increasing number of elderly, mainly elderly, mentally highly incapacitated people in our society whom we care for assiduously, physically. The problem there is that unless we have a law that permits assisted dying by advance directive, I'm being very specific now because one has to be. You can talk in vague terms and not make any progress, but actually to make progress, you need to be very specific about what you're aiming for. So these people are mentally incapacitated and they have no capacity, or inadequate capacity is a better term, and they have not made advance directives. There is no jurisdiction on earth at the moment that permits those people to be put to death. And I think that's quite right. We do not have the right to take the lives of people because we deem the quality of life is poor. Now, working in such an environment must have been harrowing, I know that. But can you imagine a society where somebody else makes a decision about your quality of life and kills you? That is not something that any jurisdiction on earth has yet allowed. And the idea of capacity and consent must remain central to this argument. Otherwise, we will enter a rather dangerous and dystopic environment. So the situation that you describe is awful, and I know it, and it's difficult to work there and difficult to justify what you're doing sometimes, but the consequences of taking action there are even worse for society, in my view. Which is why the details of consent and capacity and all these rather boring technical things are so terribly important, in my view.
Okay, thank you very much, Lisa. Let's go to Daniel. Daniel, what's your question or comment?
Barry, do you think that people should make a document saying what they would want to happen to them if they lose their capabilities, even though there isn't a legal framework for allowing assisted dying? In case of a situation where, let's say, I was hit by a bus tomorrow and paralyzed, and I had decided ahead of time that if something like that happened, I did want to die, that if the legal framework later came into place where that could happen, and you know, considering my age, there's a good chance, you know, over the next 50 years that could happen, that after the law changes, then they could look at the wishes that I had written down beforehand. And do you think maybe that should be done like alongside making a will, kind of as standard by people?
That's an interesting idea. What you're saying is that there's no provision for assisted dying by advance directive now, but you'd like to put one in the bank just in case the law changed. I think that's what you're saying. Firstly, just to talk about advance directives currently in this country, an advance directive should be called, and is called, an advance directive to refuse treatment. ADRT, an advance directive to refuse treatment, which clearly tells you that you cannot request a treatment, only refuse it. So you could put in your statement that if X and Y and Z happen to you, you want no life-sustaining treatment to be given to you at all. You can also turn over and write on page 2 that should the law subsequently allow assisted dying by advance directive, you are writing such a directive. Now, I hadn't thought of that before, but it's pretty feasible. You'd have to have lawyers trawl through it to see whether an advance directive written before a permissive law was valid once the law actually came into being. That's a fine point of law, but it's an interesting idea. Thank you for raising that. There'll have to be another slide, I think.
Well done, Dan. Okay, thank you. And Everard, what's your comment or question? If you'd like to unmute yourself, Everard,
Just a very brief point, because in my experience, when we're talking among intelligent people, the sort of people that join in with this kind of thing, who were once labelled disparagingly as London intellectuals from wherever they came, when you go to the provinces, in inverted commas, and that anywhere in the world, you're in a different world. And I think I just think I'm underlining the danger of this slippery slope. There are so many examples. Just one that keeps recurring to me was a thing on the BBC World Service from our own correspondent. I don't know if they still have that, a few years ago, where there was some guy in one of the former communist countries who was in charge of distributing European Union resources to the Romani people, and he turned up to answer the questions of the BBC person. He turned up in a Rolls Royce or something, and these people had, you know, they were just living on rubbish tips or something, and he just said, there's no point in giving these people their money, they'll only waste it. And it's that kind of environment that, if you translate it into a situation where, you know, in a medical situation where they're in a state of, you know, a resource allocation, you know, such a social environment just puts pressure on that kind of people. It's not just people view them as worthless, but they view themselves as worthless or less worthy than others, as was the case with women in the Western world for a long time. And I think there is a significant danger there. And I think one of the problems with the sort of discussion we're having now is, you know, we could come to a conclusion, not that we're likely to, and think, well, that's really good. But out there, it kind of doesn't mean anything, because you put it to a provincial hospital staffed with provincial people, and they're going to do what they want to do anyway. I have this great concern, and I don't know really, I'm not 100% sure how it fits in with this, but it's just a thing. So I'll shut up now.
Barry, I'm just going to butt in quickly just to let Elaine Stott know that I will get to you next, Elaine. Sorry, you've had your hand up for a little while, but you can put your hand down now. I'll get to you. Sorry, Barry.
Yes, I saw that. 2 quick points. Firstly, I'm not altogether sure what you mean by provincial hospitals. I spent my career in one and I have the greatest respect for it. The point you make about people's self-image and their self-worth is a very interesting and important one. And after the next question, if I may, I'll crack on, because I think I have something important to tell you in relation to that question, this issue of self-image and how you value yourself in society, and how this might affect a decision to request assisted dying. So thank you for bringing that point up. Can I deal with Elaine's question next?
Yeah, Elaine, go ahead.
Oh, thank you. It's not exactly a question. I mean, I'm listening to all these arguments, which are very necessary to make a decision and, you know, to progress the decision-making process. But what I'm going to say is very personal to me. And it's really saying that I think people debating this subject should have every sympathy with people who are living with unbearable suffering. And I myself went through a very difficult period of about 10, 15 years. I was diagnosed with multiple sclerosis in my 20s. Fortunately, I don't have progressive multiple sclerosis compared with some of the people I know. I know a lot of people with multiple sclerosis. Some of those go through absolute hell, and other illnesses like motor neuron disease, especially anything progressive. But anyway, when I hit my 50s, I'm in my late 70s now. When I hit my 50s, occasional migraine became chronic migraine. And that means if you have, it's about over 15 migraines a month. It's more complicated than that. But I was getting 18 to 20 migraine days a month. That means that a day is a 24-hour period, and I'd suffer a patch of migraine. In my case, it was about 8 hours, 18 to 20 days a month. And I didn't have medication to deal with the migraine, nor had I been able to respond to any of the preventive medicines. I'd been seeing a neurologist for years at Bournemouth Hospital. In those, I don't know if it would happen now, he used to discharge me after every appointment with a letter to the doctor suggesting 3 possible, 3 preventive migraine medications, which she could put me on, 1 at a time, of course, and I had to take each one for 4 months to test out whether it worked. And each time I went through all 3 medications, they didn't work. And that's not all that unusual with migraine. And so I was left still with a migraine, and I'd go back to the doctor after the 3rd medication and say, it hasn't worked, I've still got these migraines. It was absolute hell. Sorry, I'm probably going on too long.
Elaine, can I just butt in? I mean, what you've said is, you know, obviously a terrible situation you were in at the time. Given that I believe that you're not suffering from migraines now the way you were then. Is the question, you know, are you pleased that you didn't have the choice back then to have assisted dying? Is that where this is leading, would you say?
I made the choice then that I mean, I never discussed it with David and our two daughters fully because I decided I couldn't do it to them. And also in those days, well, now even, I'd have to go to Switzerland and I'd have to have somebody come with me. And I couldn't do that to any one of my family or even a friend. Maybe somebody from Dignitas would have helped me. But the reason I got out of the migraines was that I was suggested that I ask for a second opinion from a different neurologist, which the GP didn't think I would be funded to do that. But in fact, the committee that decided on this decided that I could go and see this neurologist in London who I was naming. And he did everything he possibly could to find me the answer. And the answer for me was, first of all, I had 2 lots of Botox injections in my skull and brow, 35 injections each time. That didn't make any difference. But then I was put on medication, gabapentin tablets. Now, I'd already had them before as a preventive possibility, and they didn't work. But the 2 things together halved the number of migraines I was getting from 18 to 20 to 8 to 10. And up to 10 migraines, I could treat that with an acute medication, which stopped it. And so,
Elaine, I'm wondering if we can allow Barry to respond in some way.
Yes,
to,
I'm sorry.
to what you've said.
But please have sympathy for people who are in this situation.
Absolutely.
My response is really quite simple. What you've just said falls quite neatly under the uncertainty of prognosis objection to assisted dying. That is, you didn't know and the doctors didn't know whether your suffering was going to continue or abate or whether there was going to be an effective treatment. So you've presented a very good example of the uncertainty of prognosis as an argument against assisted dying. So
but I don't think
shall I carry on? I see time is tight and I don't think
yes.
I'm going to finish otherwise.
Yeah, Barry, well, I'll just say that Susan is waiting, Susan Bryson. We'll get to you, Susan, before the end, but if we can just let Barry finish do his final slides and then we'll get back to you. Thank you.
So the last bit is going to be trying to put this in some kind of global perspective. What's happening in the world? How is the world dealing with assisted dying legally and ethically? And where are we here in England, in Britain, I should say? Starting off in America, for no particular reason, and I'm just going to scan through the various countries that have tackled this issue and how they've tackled it. Oregon in 1998, and currently 10 states in the United States have legislation that permits assisted dying. The principal criterion is terminal illness. And the terminal illness has been defined in terms of a number of months, which, as I said before, is a little bit suspect because who knows? It's 6 months, and it's not allowed for suffering alone. There has to be, in America, there has to be a terminal illness, there has to be full capacity, there has to be full or adequate physical ability. So those are the 3 conditions which pertain in 10 states in America. You have to have a terminal illness, you have to have full capacity, and you have to have physical ability. Psychiatric illness is excluded. And interestingly, surveys of people who sign up for assisted dying but don't actually use it give the principal reason for signing up to this program is to gain autonomy, to know that they have control. Most do not use assisted dying. Most people who sign up in America don't use it. But the reason they give for signing up is to gain self-control, to know that they have control if they need it. In Switzerland from 1998, assisted dying is permitted for terminal or incurable illness and experiencing unbearable symptoms or disability. So you don't have to have a terminal illness in Switzerland. You can have an incurable illness, but you do need to be experiencing unbearable symptoms or disability. And likewise, you must have full capacity and you must have physical ability. Self-administration, no assistance in the event of physical disability. Interestingly, in Switzerland, mental illness is an accepted criterion for assisted dying, but there are many caveats which involve assessment by psychiatrists, cooling off periods, and so on. But it is possible. Just out of interest, in Switzerland, to access assisted dying, a Swiss person must be a member of one of 3 organizations, of which Dignitas is the smallest by far, but it's the only one that accepts foreigners. That's why it's the only one we know about. But it only covers about 5% of assisted dying in Switzerland itself. And these organizations do not operate in hospitals and nursing homes. They have their own special facilities, and I believe the one for Dignitas is simply a facility in an industrial complex, not a hospital at all. Canada. Canada's pretty recent convert, shall we say, to this cause, if you want to put it in those terms. Their criteria are, once again, slightly different. A Canadian must have a serious and incurable illness. That's serious and incurable. The wording, the legal wording here, sometimes quite difficult to deal with, the difference of words and wording and how it's structured. But I'm just telling you what the Canadians have written. Canadians have to have a serious and incurable illness, disease, or disability. Must be serious and incurable. It must be in an advanced state of irreversible decline in capability. The person must be. So it's difficult to know what irreversible and advanced really mean. The person must have enduring physical and psychological suffering that is intolerable to them, and natural death has to be reasonably foreseeable. Now you can hear the legal minds working here in their legal world, reasonably foreseeable. However, in case law, this was challenged in 2017, and currently no terminal or fatal illness is required. So you can see that the law is difficult and complex, and sometimes doesn't survive challenge in those jurisdictions where there's case law, by which I mean law made by judges based on real life cases. There is a provision for psychiatric illness, but it is exceptional. That is, there are lots of checks and balances. And fascinatingly, to me, self or physician administered is allowed in Canada. That is, the person does not have to swallow something by their own hand. They can get an injection from somebody technically able to do it. But there's no provision for an advanced directive in Canada. Now, please don't ask me for the logic of the difference between the different countries. I'm simply reporting what there is, and it gets stranger later on. Germany, talking about stranger. The German legal code, they don't have a common law system, they have a codified system. So their legal code states that assisted suicide cannot be illegal, as suicide is not illegal, and therefore assisting a legal act cannot be illegal. Follow that. The ban on professional assistance for suicide has now been overturned, and facilities and assistance can now be bought. You have to pay for it, but it's a pay-for-service system there, not like the health system we have. Self-administered only, so it requires physical ability, and at the moment it's rather theoretical, as the regulation has yet to be brought into law to make it happen. But it's fair to say that Germans are moving swiftly down a path of what seems to be reasonable access to assisted dying. France is pretty strange. I'm not talking Brexit here. 2016, a law was passed to allow deep sedation, altering consciousness until death. for those with terminal illness where death is imminent and suffering not alleviated by treatment. So they've taken this rather strange concept of deep sedation altering consciousness until death, that is, sedating somebody with a secondary effect of causing their death, as their route into assisted dying. I have to say I find it bizarre, and I cannot explain it, but that's what's the path France is going down. And I tell you all these just to show you how convoluted and complex the global situation is. So the wording of the law is confusing. There's a different approach to other countries, and one waits to see how they actually manage to enact anything useful. 3 other countries where you might not, well, I didn't expect Colombia to have terminal assisted dying permitted, but it does in 2015. So very briefly, terminal illness with severe suffering is their criterion, which may be all physician administered. That's back 5 years, 6 years. As you probably all know, Victoria in Australia allows assisted dying for terminal illness with severe suffering. The criteria there are pretty stringent, and you have to wait for over a year after registering and applying to actually access assisted dying. New Zealand is a relative newcomer to this with terminal illness, and they too have stipulated a 6-month prediction of life to access assisted dying. So you can see they're pretty mixed. And here we get to the core of the issue, really, the most extreme, the most liberal, the most troubling, if you like, approaches to assisted dying in Holland and Belgium. This goes back all the way to 1973. The criteria here are unbearable suffering with no prospect of relief. There is no requirement for a terminal illness. And something that we call in the medical sphere multimorbidity or high burden of living is accepted. This is somebody who has many different illnesses, but the burden that they experience is unacceptable to them. None of these illnesses in themselves need to be terminal, but they must impose a quality of life that is unacceptable to the person. An advance directive for assisted dying is valid in Holland and Belgium, so that people who have lost capacity and have written an advance directive when they had capacity can access assisted dying. And psychiatric illness is accepted, and as you probably know, there have been landmark cases of relatively young people with severe, long-standing psychiatric illnesses who have been allowed to end their lives. The youngest being, I think, in her late teens. The conditions under which assisted dying is allowed in Holland are fairly standard. It must be voluntary, it must be persistent over time, not under the influence of others. People must be fully aware of their conditions. Consultation with at least one other independent doctor who needs to confirm the conditions above, and it may be self or physician administered. A little bit more about Holland, because it's an extreme case and a trailblazer. Currently, I think this may be an underestimate, it may be over 4% of all deaths in Holland were by assisted dying. And I think dying parties have become relatively, not common, but not unknown in Holland, where an elderly person has a bit of a knees up with their family and ends the party by ending their own lives. I've heard of several of these occurring. You might think it's bizarre, you might think it wonderful, but it's certainly happening there. Also, in Holland, 12 to 18-year-old people are allowed assisted dying if they are deemed to be mature enough to safeguard their own interests. That is, if they're old enough and mature enough, in someone's opinion, to have full capacity. Between the ages of 1 and 12, it has recently come about that assisted dying for terminal illness with parental support is allowed. That is pretty remarkable. Children between 1 and 12 can be put to death, if you like, because they're not doing it themselves, for terminal illness with parental support. That's quite shocking, but if anybody's worked in pediatrics with patients with severe terminal cancers in pediatrics. That is not as strange as it sounds. The rates in Holland and Belgium are 10 times higher than in the USA. And in 2016, and you need to be sitting comfortably to hear this, because this is pretty extreme. In 2016, Dutch ministers of health and the Minister of Justice proposed permitting self-administered assisted dying for the elderly who had no terminal illness or suffering unbearably, but were finished with life.
Mm.
And in 2021 April, this month, sorry, that should be last month, I beg your pardon, I got my months mixed up. Very recently, notice has been given that this law is to be drafted, that is, put before Parliament, but it is progressing, which gives you an idea of just how far out on a limb or up ahead, or in a bad place or in a good place, depending on your point of view, Holland is. It is quite remarkable what's happening there in relation to assisted dying. Just briefly, the Dutch did some research into factors implicated in being finished with life, and these are translated from the Dutch, so the English doesn't read that well, but you'll get the idea. The factors implicated in being finished with life are a sense of aching loneliness, the feeling of not mattering, the inability to express oneself, multi-dimensional tiredness, and an aversion of feared dependency. Those were the reasons people gave for being finished with life. Just 2 more slides. I know we're short of time, but this is probably of interest to everybody. Where are we here in the UK? Well, interestingly, it starts a long, long time ago, 1931. The president of the then Society of Medical Officers for Health proposed a voluntary euthanasia legislation bill, but for the incurably invalid, which is a very shocking thing to read today. In 1935, the British Voluntary Euthanasia Society, later known as EXIT, was founded. In 1936, there was the first attempt to reform the law in England. Then all the way to 1961, where there was a big step backwards, or a block set up, where the Suicide Act stated that the legal system can allow up to 14 years in prison for anyone who assists in a suicide. That's been a major obstacle to change or progress, depending on your point of view, in this country, the Suicide Act, and which took us all the way to 1997, when a vote in the House of Commons on the issue of introducing a doctor-assisted dying bill lost by a very large margin. Up to 2003 to 2006, we have current affairs. The Labour peer Lord Joffe made 4 attempts to introduce bills that would have legalised physician-assisted suicide. All were rejected in Parliament, and in 1 or more of them, I think the Bishop of Cardiff was instrumental in lobbying Parliament and setting up his parishioners to send letters to MPs. 2014 marks the start of the latest set of attempts by Lord Falconer, who introduced an assisted dying bill into the House of Lords. It reached committee stage and it was timed out. Between 14 and 16, Falconer's proposals were introduced and defeated 3 times. But last year, Lord Falconer reintroduced the bill into the House of Lords, and it is awaiting a second reading. Some might say this is our chance. When I say our, those in favour. Up to 50 MPs have now signed a letter supporting the bill, cross-party. It hasn't got to the House of Commons yet. This is a piece of legislation originating in the Lords. Unusual, but it does happen. So there is a potential in the United Kingdom for things to change. But I think we're all going to have to lean on our MPs if we are so inclined. And what about the lobby, the political lobby in this country? And this is my last slide, I promise. The Dignity in Dying campaign has the following position. It's an extremely conservative one. It is that assisted dying should be limited to the terminally ill with full mental capacity and who have physical capacity as well. So full mental capacity, terminal illness, and physical capacity are their criteria, with a waiting period for reflection requires assessment by 2 doctors and a High Court judge, which is an exceptionally strong level of control, shall we say, in comparison to other countries. I don't think any other country requires the involvement of the court in every decision for assisted dying, which is what I mean by a very conservative approach. And in answer to a question that was raised earlier about who supports this, whether it's sophisticated people or unsophisticated people, the latest poll, and I can't remember who commissioned it, but the latest poll of the United Kingdom shows that over 80% of people support legalized assisted dying in this country. So at this time, I'd say, if you have a view, write to your MP and keep on writing. Thank you.
Thank you very much, Barry. I know we've gone over time, but this is people I know are very interested in this topic, obviously. I'm going to just, Barry, if you're happy, I'd like to run on a little bit longer because 4 people still want to ask a question. Is that okay with
Absolutely
you, Barry?
fine with me. I'll
Okay.
stay as long as you want me to.
If anyone needs to leave now, then obviously, you know, it's been good to see you, but we'll keep going for a little bit longer. So Susan Bryson, you've been waiting patiently for some time. Susan, if you'd like to unmute yourself, you can ask a question or make a comment.
Hello, Susan.
Okay, look, we'll come back to you, Susan, when you found out how to unmute your iPad. Let's go to David Nunn.
I've unmuted it.
Oh, you have, Susan. Okay, go ahead, Susan.
Can you hear me now?
Yes, yeah.
Oh, good. Barry.
Hello.
Hello?
Hello, yes, carry on.
Right. If this desirable state of affairs should occur, with all the caveats and safeguards and everything, it would be my opinion that it should be allowed for prisoners as well. Because if you've got a huge life sentence ahead of you and no possibility of release, you might think your life's not worth living. I'm not saying that everyone's going to think that, but it should be an option. And there are lots of very mentally ill people in the criminal justice system, in prisons. It doesn't seem fair that prisoners wouldn't have that autonomy as well.
Well, in answer to that, I must confess I've absolutely no idea whether assisted dying is extended to inmates in prison elsewhere in the world, or whether incarceration is regarded as unbearable suffering. You brought up an issue that I haven't even begun to think about. It's completely novel. So I have no idea how to answer it other than to say it's very interesting, very stimulating, and very demanding situation you've brought up.
I'm interested because I did a lot of work in prisons for some time of my life, and I've always been interested in how society treats its offenders. And it would seem to me that that would be very unfair if this right wasn't extended to them. But it is a complex issue, of course, and there are people who would think that they should have a long time in prison to suffer for what they've done, but I don't think like that. So.
Okay, thank you very much, Susan. Let's go to David Nunn. David.
Thank you, David. Very interesting talk, very interesting indeed. Can I ask a question? Why the last slides there that you gave, Britain seems to be very, very much behind the curve here. Why is that? Why is it? Because Britain isn't a secular society, really? It has 26 bishops in the House of Lords. Is it because they don't trust our doctors or don't trust us? We'll all be bumping each other off. I mean, what is the reason why Britain is so behind the curve? Over.
I really don't know. something to do with the quality of our parliament, the way we govern. I can speculate, but I'm as puzzled as you are.
I'm happy for you to speculate.
I would end up saying nasty things about our system of governance, but that's not what we're talking about. We can leave that for another day.
I think the comment I would make is that if that's the sum total of countries that do have some form of assisted dying, Barry, it's still a very small percentage of the total number of countries in the world. So we may be behind some countries, but not the vast majority.
That is very true.
Okay, thank you, David. Let's go to Bronwyn. Bronwyn.
Mine's not so much a question. Thank you very much, Barry. That was really interesting. I lived for 11 years in the Netherlands, so I kind of understand the culture. So perhaps if people are looking at the lists of requirements there and thinking, wow, they're just a much more liberal society than we are. They have very strong thoughts about things. What I understand, though, from the system in the Netherlands, you still have to have two doctors have to sign off the assisted dying. It's still not just you decide and have a party and pop yourself off. There still are legal procedures to go through in the Netherlands before you can go down the assisted dying path. So that was all I wanted to say.
Yes.
Thank you. But great talk. Thank you.
Thank you, Bronwyn. Just got a couple more to go. Lisa and Richard. Lisa.
Yes, I just wanted to add that the idea of a death party, I think, is quite an appealing one in lots of ways. I had attended a very beloved aunt's funeral, and all of the family members had made special effort to go there. And I remember feeling really sad that she wasn't there and how much she would have liked it, because just everybody was there. That's all I wanted to say. Death party sounds a good idea.
Yes, I saw a video on one, and just to come back to a previous point that Bronwyn made, the person involved did fulfill all the criteria and had a terminal illness, but decided not to take their lives in private, but to make a social family event out of it, which was, on the face of it, on the video, this is a big caveat, was a fascinating mixture of joy and sadness.
Yeah, I'll just throw in that one of our Dorset Humanist members a few years back had exactly that. I mean, she knew that she was dying of cancer and only had a few months to live, and a number of our members went to a bit of a do at the Miramar, and she was present, which was great. So you can always do it if you know when you're going to die.
Yeah.
Okay, Carolyn and then Paul, and then I think we'll need to draw a line under the questions. Carolyn Meller. Carolyn.
There we go. Hello, Barry. Hi, David.
Hi. Go ahead.
Right. In the interest of full disclosure and transparency, I wanted to note that in 1996, we were heading for recession, and it was under a Conservative government, that my husband died in my arms, having been in a coma for 3 weeks, but was responding in private on one-to-one. And it was said to me that they didn't have the budget for me to be trained to look after him, or for his room at home to be set up with all the stuff that he would need, and we couldn't afford to buy it. So I think it's naive to think that finances and resources don't come into the equation. They very definitely do.
Okay.
Okay, Barry, did you want to respond, or should we go on to the next?
It's almost impossible to respond to specific situations because they're all so unique.
Okay, okay. Thank you, Carolyn.
It does happen.
Okay. Let's go to Paul and then Judy. I see that you've just got in at the last minute as well. We'll get to you, Judy, as well, but Paul first.
Barry, I thought it was a super talk. I thought it was extremely well done, extremely clear and logically put out. I have a slightly radical question in the interests of freedom of the individual. how hard is it to get hold of the appropriate drugs if you wanted to prepare for the future where you might want to take your own life?
We are such a safety-orientated society that if you want to buy a few more paracetamol than one packet, you have to justify yourself to a spotty youth behind the counter. So the simple answer is very, very difficult.
Okay, thanks, Barry. And I'm afraid it's not a service that Dorset Humanists is currently providing, but come back at some point in the future.
One way to boost membership.
Yeah, yeah. Okay,
and
Paul,
then reduce it.
Yeah. Let's go to Judy for the last question. Judy.
Well, thank you very much. This may be outside your remit, but I'm just curious if you know anything about the status of advanced dying in Israel, as you've mentioned various other countries throughout the world. Thank you.
As I understand it, Israel is close to being a theocratic state, so that the religious view holds sway. And to the best of my knowledge, Jewish religious law does not permit assisted dying. I don't believe Israel permits it at all.
Okay, thank you.
Okay, well, I'm sure that you will all have the same view that we've had an incredibly informative talk from Barry this afternoon, and we fielded lots of questions. So Barry, thank you very, very much. And if everyone would like to just show your appreciation in some way.
Thank you very much.
Thank you, Barry. Lovely to see everyone, and some people are Zooming, I think, for the first time, or we haven't seen you recently, so it's been great to see you. That's it for today. Do come back again soon, and we'll see you all again very soon. Lovely to see you. Bye for now.